Hello, everyone. Welcome to the third episode of the special edition of ICPA Clinical Series. And as you all know, this special edition is brought to you by the Indian Society of Digital Dentistry and powered by World Dental Association. And today is the third episode, and we are covering a mixture of two powerful forces that are shaping the modern dentistry, that is implantology and digital dentistry. We have already completed two episodes where we covered two relevant topics, and today we have got a totally different topic where when I myself read the introduction, I realized I don't know much about it. And to speak about this topic, where we are trying to differentiate conventional dental materials from digital materials, I was not aware of this distinction at all. We have the right guy to speak about it. We have our guest speaker, Dr. Vipin Mahurkar, seasoned periodontist and implantologist, and also a digital dentist. And as I told, this show is powered by World Dental Association, one of the largest as well as the most dynamic groups on Facebook. We have the co-founder, Dr. Anand Mohta here. He is an endodontist, one of the earliest micro endodontists, and he has been my partner in crime in many ventures. We have written books. So it's always a pleasure to have him. So I hand over the show to Dr. Anand Mohta to introduce Dr. Vipin Mahurkar and begin the proceedings.
Thanks a lot, Rajeev sir. Good evening, Rajeev sir. Good evening, Vipin sir, and good evening to everyone who has joined in. As Rajeev sir already mentioned, we have read dental materials since first year, but somehow dentistry has changed a lot in these past years, and there is a lot more to learn. And Vipin sir is here to enlighten us about it. Just a brief introduction about Dr. Vipin Mahurkar sir. He completed his MDS in Periodontics and Implantology, which is his domains of expertise, but he has ventured way beyond them now. He has founded the Synergy Dental Clinics in 1999 and has been in private practice for 25 years, entered digital dentistry in 2011, and has consistently modernized his dental practice in the last 14 years. Founded Synergy Dental Lab in 2014, and in the last 10 years, he has transformed his lab into a cutting-edge digital dentistry lab by modernizing it with the latest workflows and digital dental materials. Dr. Vipin sir has also launched Synergy Dental Education to conduct training courses for dentists in implantology and digital dentistry. Last but not the least, Dr. Vipin is the director of Indian Society of Digital Dentistry, that is hosting its second edition of International Digital Dentistry and Implantology Conclave in November 2024 in Pune. So that's about Dr. Vipin sir. Vipin sir, the stage is yours.
Good evening, everybody. Thank you, Rajeev. Thank you, Anand, for the introduction. Whenever you hear your own introduction, you really feel euphoric, and for somebody is talking good about you, because there nobody can talk wrong about you. So, yeah, before starting my presentation, I am so proud to be one of the directors of Indian Society of Digital Dentistry, and we are planning an international program in November this year. So please register for that conference, because we are getting 10 speakers from all over the world for this conference. If you click on the QR code here, you'll get more details about it. Now let me begin with my presentation today. Today I'm going to talk, most of the time in most of the forums I have spoken about dental implants, surgical aspect of dental implants. I have spoken about how to place implants, all on 4, all on X, then GBRs. Then I have spoken about prosthetic aspects of it. But this is a topic which is very close to me and I feel is very important. One of the major reason is, we being dentists, we have learned about dental materials right from our first year of BDS, and things have changed since then dramatically. I joined dentistry in 92 as a first year student, and since then what we have read in our Skinner Phillips and what we are doing today is totally different. And fortunately or unfortunately, very few dentists understand the dental materials, because since I'm running a dental lab and we get a lot of work from outside, and unfortunately very few dentists understands the changing trends in dental materials. So since I own a lab, I get to learn lot about those products, and I realized that this is a topic which should reach every dentist and every clinic. So when Raju called me and said we have to talk about some digital workflow, I said I would like to talk about something which is very close to my heart and which is very less spoken about in the dental scenarios. So then I decided to talk on dental materials today. When I speak, let me introduce myself. I am running a dental clinic in the name of Synergy Dental Clinics. That's my staff. We have a 4-chair clinic in Borivali, and nothing. All the slides that you are seeing now is are. I'm sorry, something. Okay, just give me a second. Or whatever cases that you will be seeing today couldn't have been possible with the staff. You can see me, myself, my wife, and doctors who are working with me, Dr. Dhwani, Dr. Shweta, Dr. Sonali. They are consistently working hard to upgrade ourselves. So thanks to them. Then we have a dental lab with in the name of Synergy Dental Lab, and with a workforce of almost 25 people. All of them thrive to give the best to the dentists, and we do all manual as well as digital workflow, right? uh, I got into digital dentistry because of this machine. This is my first digital of course RVGs and everything are digital materials, but all this uh, I ventured into digital dentistry when I purchased my CBCT in the year 2011, and since then I just got fascinated toward digital dentistry, and I tried to improvise myself. So to begin my presentation, I would like to show you a case. If you can see, there is a upper anterior teeth present, and few of them are replaced by implants. If you see this, these two teeth that are the central incisors are on dental implants. They really look natural, and they are made up of Emax crowns. So imagine crowns on dental implants, which are made up of Emax, which all the aesthetic dentists in the world love these materials. They are bonded on zirconia abutments. So to get this type of aesthetics, right, we needed the color of zirconia from inside and Emax to give the natural look, right? And those are zirconia customized abutments. But to achieve this and to uh, get the zenith of to get the zenith, what was most important was these PMMA crowns that were given right at the time of implant placements, right within 72 hours of the implant placement. So these are the crowns which shaped the gingival zenith for me, and that's why I could give that aesthetic to the patient. So when we started with this, the patient had come with this broken anteriors, which we extracted, we placed implants, and we gave immediate temporaries, and these temporaries gave us the result that you can see in the background. So the temporary solution is the key to success. That's what I always felt, that whatever you give temporary to the patient, you should make it so perfect that everything that is made in temporary has to be replicated in the final prosthesis. So CAD-CAM has changed our life. CAD-CAM materials that are available in the world are either additive materials or subtractive materials. What are additive materials? Additive materials are something that are made in your printing machines, right, on 3D printers. And subtractive materials are the materials that are milled from a block. So additive materials are added one by one, layer by layer, and the structure is made. And subtractive material is what from an entire rock we carve it into whatever desired design you decide. So to make my presentation simple, I have classified the materials into temporary materials on the tooth, permanent materials on the tooth, temporary materials on implants, and permanent materials on the implants. So the temporary materials on the implants which we most commonly use are printed temporary, which are also PMMA, but not as strong as milled PMMA. And permanent material on the tooth, we'll talk about all these materials slowly as the time permits, if Raju allows me to speak for a longer period. So let's talk about the printed temporaries. I call them as my first temporaries. So whatever, even if I'm making a crown on a single tooth crown, first thing is that I make a printed temporary, which is checked in the patient's mouth. Everything is shaped, bite is checked, everything, and then we shift to the permanent materials. And when we give this printed templates, these are not given to the patient. This is just for our analysis, just to check how the bite is, how it looks, how the shape is, what color to be given, how to change the, whether we need to change the preparation. All these things are determined by my printed templates. Right, all the temporaries are, most of the temporaries that we are using, initially we used to use a lot of pro temps, right? That is clinically we used to give temporaries, but nowadays we have shifted totally to digital temporaries. They are made up of PMMA. So PMMA is what? PMMA is a polymethyl methacrylate polymer, right? Which is it is kind of an acrylic. It is an acrylic or a plastic which is uh, strengthened to a level so that we can give temporaries, at least at a temporary level. It is polymerized methacrylate, right? The advantages of PMMA is that it is excellent clarity. It has got a good UV resistance, good abrasion resistance. It has got good hardness and stiffness. But the biggest disadvantage is that you cannot use it for a longer period. It has got poor impact resistance. You cannot use these PMMA as a permanent material. But the science is advancing so well that very soon you will be giving lot of permanent prosthesis into PMMA. And one of the latest product that I am using is a modified or a resin reinforced or zirconia reinforced PMMA called as Bracam Multicom. It has got excellent aesthetics, and this we have started giving to our patients, especially those patients who are going to come after few years to us. So what the company claims that you can give this materials for 3 years and it will not fracture, at least 3 years. This. So what has been changed? These type of PMMAs, the newer PMMAs like Bracam Multicom, and there must be many more companies who are manufacturing it. This is the one that I am using quite regularly. Is it has given an approval for prosthetic teeth also because the strength they have increased. It has got good color matching as they are giving with different shades as well as gradation in the shades like translucency at the top and opacity down. Better optical and aesthetic properties. Wearing time is up to 3 years. What does this means? They are long-term temporaries. You can give them in the patient's mouth at least for 2 to 3 years. I will not say always 3 years. You can keep it in the patient's mouth, even the full mouth prosthesis for 2 years. Suppose a patient comes to you and you are planning a full mouth implants, and the patient says that I'm not able to come for another 1.5 years. You can anytime rely on these type of materials that are available and give them to your patients. Right. So how is the PMMA different from the latest multicom PMMA? Is the wearing time. The wearing time is 2 years or 3 years in the newer material as compared to the older PMMA that we were using for 6 months. Right. There are a lot of chemical things that have been changed inside. If I start talking about those things, I'll be needing 1 hour for every material, which we don't have. And I don't want you all to bore a lot about the material science and all those things. Since I have a lab, I keep on reading about these materials, and that's how my knowledge keeps on increasing. Now we'll come to permanent materials that we are using. One of the most common materials and time-tested materials that we have been using on either permanent prosthesis on our patient's teeth is PFM, that is porcelain fused to metal. But I think last 5 to 7 years, most of the good dentists have stopped using this material because of its own disadvantages, its color disadvantage. The metal, sometimes metal throws away the soft tissue away, and it reacts with the soft tissue. And definitely we have much better. I'm sorry, in this slide it's printed and there's a zirconia. I'm so sorry. This PFM, glass ceramics, and zirconia, these are the permanent materials that we are using now. So what are the interesting facts about the materials that we are using nowadays that are digital materials? I'm not talking about PFM. PFM is a material of the past. Anything that is casted or pressed was used some 5 to 7 years back. If you all are not using it, you all are behind time. You should start relying on digital materials for not only for uh, uh, the, not only for cost purpose, but for better aesthetics, for better function. And I'll explain you why. The hardness of enamel, everybody knows, is 300 to 400 MP, and what we layer on the metal is a veneering ceramic. It is 200 to 620 MP. But the biggest disadvantage is the metal inside. It is a cobalt chrome metal, which most of the gingiva rejects. It doesn't accept it. Cobalt chrome is not very well accepted by a soft tissue. Since I am a periodontist, Raju is a periodontist, he will understand. We see so many cases where we see periodontal issues because of metal prosthetics. Then the hardness of zirconia, which when it was introduced, right, was 1200 to 1250 MP. You remember when zirconias were introduced in the market, they used to give a hammer and just ask you that just hammer this, and you will see that the crown will never fracture. The reason is that it had a tremendous hardness. But do you want such type of material when you're opposite, and when the hardness of your enamel, that is of the opposite teeth, is 300 to 400 MPa? No, it is going to wear off the opposite tooth. Right? You need something which is close to the enamel. You have to mimic nature when you are giving prosthesis. So they started working on it. They started reducing the hardness of the material by doing few things which I'll talk later in this presentation. And the newer zirconia had a lesser MPa, that is 800 to 1200 MPa. So what are the material options on the tooth? We use composites. Now, hence, after this slides, everything I'm going to talk is, it will be about digital materials. I'm not going to talk about casted metal or pressed metal. Everything is milled. Everything is milled in a 5-axis milling machine. And then we get the results. The accuracy, the fit, everything is achievable only because of the digitalization of our dental world. So the material options are composites, glass ceramics, zirconia, and hybrids. We'll go into it. What are the composite materials available commonly in our market today, in the Indian market? Vita-enamic and HIPC. Right? What is a Vita-enamic? It is a unique hybrid ceramic with a dual ceramic composite network. Right? It is a composite, but it has, you'll see the next slide. How does it? It's a Vita ceramic. This is from the company. I took it from the company. It has got a good impact strength. Right? So ceramic polymer dual network, where they have hybridized, or they have mixed ceramic along with polymer, right? 14% polymer and rest all is ceramic. It is mixed together, and then you get a material called Vita-enamic. It's an ideal material for inlays, onlays, or single tooth non-functional areas. And when you do it in a lab with CAD-CAM, you'll get the accuracy as well as the properties of these materials. It is a unique sensitive tooth. But if you do it in a lab with CAD-CAM, you'll get the accuracy as well as the properties of these material are excellent. Another material that is available, that is composite, which can be milled, is a HIPC, which is again made by Bredent. Bredent gives excellent prosthetic materials. I love their prosthetic materials. They are very well studied. And I really, whichever materials which they sell, I buy it for my lab and for my patients. So HIPC Bredent is a high impact polymer, a two phases composite. It is a typical, I use it in my full mouth cases where the framework is made of Bio-HPP, that is a peak material, and HIPC composite is bonded to it. I'll show you one case later in the later part of this presentation, and you will come to know. Then we'll come to glass ceramics. Glass ceramics, how many of you know? Whenever we talk about glass ceramics, everybody says it's Emax. Glass ceramics basically are broadly classified into two parts. Ceramics, that is feldspatic ceramic. Trilux Fort is a material given by Vita, one of my favorite material for non-load bearing aesthetic region. Another materials which most of the aesthetic dentists or dentists in the world uses are Emax, that is lithium disilicate. So feldspatic veneers are made from feldspar, a naturally occurring mineral that is ground into fine powder and combined with resin to form a durable material. Right? This material gives excellent, it has got the best translucency amongst all the materials, but it has the strength wise, it is not as good as other glass ceramics or lithium disilicate. Of course, Emax is a material of choice for most of the cases. I'll show you two patients right now of both the materials. The difference between feldspathic porcelain and lithium disilicate is the flexural strength. Flexural strength of feldspathic ceramic is 340 MPa, which is very much close to the enamel. You always remember it. This strength is very, which we desire to give to most of our patients, because we want to give enamel on our patients, right? So feldspathic porcelain or Trilux 4 will always is very close to enamel as compared to other materials available. But the biggest problem is it cracks, and it is very technique sensitive. The preparation should be minimum. It has to be bonded on enamel only. Dentine doesn't get bonded to this material. When you put hydrofluoric acid for a longer period on this, it becomes more brittle. So it is very technique sensitive, but it is one of the most translucent material available in the market. Another biggest disadvantage or advantage is when you are using veneers made up of feldspathic ceramic, your uh, bonding cement should also be translucent. Otherwise, it will just throw away the color of the bonding cement, right? So Vita Trilux 4th is a material. Nowadays, you get it in these blocks. You should nest your crown perfectly in this block so that you get the desired translucencies. Again, nesting means placing the crown in this block has to be understood. You have to convey everything that you need, convey to the lab whatever you need, whether the patient's translucency level is high or low. Accordingly, the crown or the veneer is nested in this block, right? So shade accuracy is excellent, easy to polish, abrasion is similar to enamel, and it has got a high success and survival rate, but it is technique sensitive, right? It has indications are less, and you have to nest it perfectly. So we use it for single veneers, especially non-aesthetic area, non-occlusal load bearing areas with minimum invasive. If the inner structure of the tooth, right, is dark, that dark color is going to get replicated in this material. So if you want to change the shade, this is not the material of choice. Then you have to go for Emax. So you can see one case done. All these veneers are done with Trilux 4, and we have got very good results with this. Now we'll go to the another material which is material of choice for most of the full mouth tooth supported full mouth cases that we are doing. It is lithium disilicate, that is Emax, right? You can give veneers up to 0.3 millimeter, minimum invasives, inlays, onlays. You can nowadays we are giving molars also with Emaxes, right? You can see a full mouth case where all the teeth were upgraded. The entire case was done by my wife, Dr. Pallavi. I just gave her the support of my lab, and we each and every involving the posterior right teeth which were on implant. So there is a zirconia crown and an zirconia abutment and Emax crown on those teeth. And we have been following this case since last 6 years. Not even one tooth is chipped. Even for posteriors, we have bonded them successfully, and we have got good results. I hope everybody can appreciate the colors, the chain, the bite, everything. All the steps that are required in FMR were done in this case, right? So we started here, and then that's a post-operative. We give on this case was done by Dr. Praveen Salanke with our lab, and you can see an onlay prepared by Praveen, and then given to the patient, right? I would like to talk about another material. Sometimes when the bite of the patient is very high, you want to use a bonded ceramic material, but you feel that Emax is slightly brittle. Then Vita gives us beautiful product called Vita Supremity. It is again a glass ceramic which is reinforced by zirconia. So what they have done is that they have given a material which is slightly more stronger, and this is especially indicated in posterior areas where you want to do minimum preparation, where you don't want to give a zirconia crown and you want to bond a crown. So this is one of the material of choice for posterior. It is slightly more opaque than the uh, than the Trilux Fort or Emax crowns, but of course one of the materials you can think in few indications. Now we'll come to the material which has changed the digital world is zirconia. Zirconia came into market in the 1990s, right, in the form of endodontic post and dental implants were tried with zirconia. Mill zirconia became commercially available all over the world in 2010, and it started picking up in India, especially after 2012, 2013. If you see on the periodic table, zirconia is right in the fourth row, that is fourth column. I'm sorry, fourth column, which is where the above is titanium. So you all these materials that are in this column, titanium, zirconia, and ahead, all these materials are the most biocompatible materials. That's why titanium, zirconium implants are made, because these materials are not rejected by bone or body easily, right? Very rarely you must have seen an allergy for titanium, which is must be 1 in 10 lakhs or something like that. I have just heard of one case which was allergic to titanium. Otherwise, all these materials are excellently biocompatible. Zirconia being white in mud color has been we have started using it in our prosthetics. Right? A lot of advantages, disadvantages. I don't want to read all of them. Right? But zirconia, when we talk about, we should understand what material we are giving to our patients and where to use which materials. When they were introduced, they used to give crowns, which are monolithic crowns for posterior, which had an excellent flexural strength of 1450. It had hardly any translucency. It was very opaque material. Could not be used for anterior region because they used to look like a white colored rock. These materials are rarely used nowadays. We have shifted to 4Y and 5YW, 5Y zirconia. What do you mean by 4Y, 3Y, 5Y zirconia? It means that yttrium was added to zirconium oxide to make it more translucent. And as they started removing zirconia from it and putting yttrium to it, it started becoming more translucent and the strength started becoming less. What we want to so what is happening that the entire zirconia market is trying to match Emax, and the entire Emax market or glass ceramic market is trying to match zirconia. So there is a clash between these two materials all over the world. We are coming to a level where we can get a mixture of both, or we can get ideal properties in both the materials, and then you'll have to select which materials to build. I know this is getting slightly confusing, but anything you want to get bonded, you can think of glass ceramics. Anything you want to lute, you should use a zirconia, right? Zirconia, 4Y zirconia and all those things we used to use only for 2 units or 3 units, but newer zirconia have got such beautiful aesthetics and strength that we have started using them for full mouth implant cases also. I'll show you a few cases as we go ahead. The 5Y zirconia are the zirconia for anterior region. They give excellent aesthetics. Nowadays, you get zirconia where they have kept 3Y at the cervical level, 4Y zirconia at the middle level, and 5Y zirconia at the apical level to give the aesthetic as well as strength. One of my favorite materials is Zenex by Aman Girbach. Another good material that I like is Luxor, again by Bredent. These are the materials that have changed the zirconia market for aesthetic as well as strength purpose. Right? These are the materials: Solid Zenex or Solid FX, then Bredent, Luxor. And Ivoclar Vivadent gives a beautiful zirconia called Zircat. 3M Lava is something I'm not using a lot because somehow I'm not getting the aesthetics what these materials are, but still they have marketed themselves or placed themselves in such a good level that people are asking for it in my lab. But if you ask me which is the zirconia of my choice, I will go for Luxor's Head or Solid Zenex. This is a full mouth case which was done by in Luxor in our clinic. You can see all the crowns are milled and only then they are only glazed. We have not added any stains to it. And the Luxor gives such beautiful aesthetics that they don't look like artificial teeth. They look as much as beautiful as glass ceramics. I hope you appreciate that. This is a case where no other material would have been possible. This is a case where the patient, all the teeth were treated and the patient had acquired uh, class 3 type of occlusion. We had to do a lot of changes in his mouth. We didn't do any surgical changes. Only a few implants are there in his mouth. But we tried to get him back to class 1. And the material used is a Zenex material by Aman Girbach, again one of my favorite materials. There are a few implants in the posterior. This patient also had SMA, and we treated his mouth opening initially. Then we uh, rehabilitated him, got his occlusion back, and we have been following this patient for almost 4 to 5 years, and there is no complaint as such. Uh, Another case with full mouth Zenex material, FMR case, right? That's the pre-op, post-op, and that's the aesthetic of the patient. I'll show you one case where we have used combinations of lot of material. This patient had come to me from Georgia, and she had a collapsed bite, and she was ready to pay whatever money. She said, use whatever is best in this world, but I want my smile to be improved. This is my mouth right now. Her anterior bridge was shaky, so we took her scan. You can see a lot of teeth, and that was her smile, right? Loss of aesthetic smile line. We took a CBCT. There was a little bit of bone loss also, because of which you can see the drooping of her lip on the left side. So we decided to have an FMR in this case. These are the places where we plan to do GBR and then implant placements. Like, we took a scan. After removing the bridge, this was a condition. The teeth that were you holding the bridge, they were all post and core treated. Right. So on diagnosis, we had missing teeth, aesthetic loss, loss of soft tissue, loss of hard tissue, loss of vertical. We digitally mounted her on Class B on a semi-adjustable articulator that is made by Aman Girbach. So this is a digital articulator which can be mimicked on the screen also, right? Then we transferred everything in temporaries in her mouth. Then we made stent. That time surgical guides were not available in the world, so we used stents that we used to do. Grafting was done, implants placed, temporaries given, everything planned on ExoCAD. I've been using ExoCAD now since 2013, and my boys have expertized it. This is a wax up which we tried in her mouth for her approval. Right? Then the abutments were designed accordingly. So these abutments were made up of zirconia, and everything else were made up of Emax. You can see there is a lot of recession in the upper right central incisor. The only reason why this happened was because we placed this implant more buccally to avoid the incisive canal. And now then we treated that patient. This is the bite. Then I did a small gingival graft in this region to get the soft tissue down. Now the patient was in Georgia. Then she went back to Georgia, so I don't have a post-operative photograph later. This case was done in 2015, but I do get mails from her and saying that everything is fine and nothing has been lost, and so I feel happy for that. So that's what is her post-operative OPG that she had sent to me. I think 1.5 years back, where she said everything is fine. I asked her only at least an OPG to be sent, which she sent, and everything looks fine, right? So that's lateral excursions, everything. That's her occlusal photographs. That's the smile that we achieved. So from here to this, all these things are possible because digital world has made our life very easy, right? So all these things, if you want to learn more, please register to the conclave that we are planning, because we are trying to get the best of speakers who can talk about all this type in digital occlusion, digital materials, implant placements, and a lot of things. I'll come back to my presentation here. So these are the materials that we are using most commonly on the teeth. It is the feldspathic ceramic, lithium disilicate, modified lithium disilicate, and zirconia. You choose whatever material you want according to the indication of the patient. Unless you don't understand these materials, it will be very difficult for you to give right materials to your patient for long-term prognosis. So understanding the materials is the key and very important part if you are doing dentistry on a regular basis, right? If you all have any difficulties, you can contact me on WhatsApp or anything, and please keep on asking. Now I'm going to talk about a revolutionary change that is taking place all over the world. Is a PEEK. PEEK is polyether ether ketone. It's a plastic material. It's a chemical structure is different, which is a plastic material, which is changing a lot of things in our world, especially in implant dentistry. Now we are not talking about tooth supported, but implant dentistry. This peak is used in a lot of things. They are used in orthopedic implant. They are used for orthopedic dressings. Lot of places, even for spinal surgeries, they are using it. One of the indications of peak, one of the um, places where peak is used is dental implants. People very soon we can customize our implants made up of teak, since it will be more flexible and less chances of breakage. But all these things are still under study, so we'll not go into it. But peak or modified peak we are using more commonly for our temporaries nowadays, as temporary abutments on which we can give our composite crowns. Of course, the peak is also getting modified. Bio-HPP is a modified peak again made by Braden, which is my favorite material for temporaries, and also in few cases on my fixed prosthesis, fixed crowns also. So if I need a temporary abutment, peak is an answer. But I need something softer material with elasticity as my permanent abutment. I will always prefer to have Bio-HPP. Nowadays, companies have started giving you Bio-HPP abutments also. Of course, another indication of peak is you can use them for cast partial dentures like this, right? They are more flexible, light, and since metal is more harsh than these materials, there's a small disadvantage of this is the polishability is not as good as metal, so you should choose them very rightly, these materials. But the biggest advantage is the weight. They don't have any weight. It is absolutely less weight. We use these materials on implants also. I'll show you few cases later. I will not go into detail of this because I have already 10 now. So we'll rush through this. Sorry for a lot of things here. This is all about peak. We can make dentures or materials on bio. These are, sorry. I'm sorry. Okay, so all on four cases we do lot of with peak with composite layering or peak frameworks or Bio-HPP frameworks with zirconia crowns onto it. We are doing lot of cases. I'll show you few of them as I go ahead. Of course, this is a Bio-HPP abutment on which a zirconia crown has been delivered. Right? You can see the cases. A crown on a Bio-HPP abutment. It is very biocompatible, these materials, so they don't cause irritation to the gums also. Right? Now I'll talk about materials that are used for full arch cases, right? Full arch implant cases. We talked about teeth. Now we'll talk about full arch implant cases. What do you expect from a full arch dental material, full arch implant dental material? It should be biocompatible, of course. It should be of less maintenance or no maintenance. It is biophysiological. What do you mean by biophysiological? Since an implant doesn't have a periodontal ligament, the elasticity should be provided by these materials. Like peak Bio-HPP, they are more elastic compared to metal zirconia. So of course biophysiological. Then polishability, you should be able to polish in the mouth or in your clinic. Aesthetics, of course, repairable, lightweight, CAD/CAM compatible. No material cannot should be used without CAD/CAM compatible. And most importantly, affordability, especially in the Indian scenario. So what are the materials available? We used to use a lot of acrylic fused to metal or the hybrid processes that we used to call. Then we used to use a lot of casted metal with ceramic layering. I have used them a lot in the initial decade of my career. But then when MLS came into the market, I started getting more passive fits with MLS, so porcelain fused to MLS. Then once zirconia and all these materials became prominent, I have shifted completely to these materials, or the world has shifted completely to the newer materials like full contoured zirconia, titanium framework with zirconia crowns onto it, peak with composite layering, Bio-HPP with composite layering. Lot of things can be done. These are the materials. If you can see, this is one of my first all-on-5 cases where we had done uh, lower overdenture and upper hybrid prosthesis. You can see sinus lift on the right side and on the angle on the left side, an angle implant to avoid sinus lift. Right, this was a hybrid prosthesis that we had planned that time, and an overdenture with locators. I have delivered these prostheses a lot, but later when newer materials came, I started calling back these patients and shifted them from better materials than what we used to do. In today's world, please stop using these type of materials as they cause lot of plaque accumulation, they invite lot of plaque, as well as they are very irritating. Acrylic is not very good to the mucosa compared to the newer materials that are available. So then the time we started getting MLS, we started using lot of MLS. Again, it was a CAD-CAM compatible. MLS is nothing but metal laser sintered. That is, it is an additive technology in which the metal is added according to the CAD-CAM planning, and then it is sintered to become. So the metal initially is added in the powdered form and it's sintered to become hard. It is a cobalt chrome material, of course. Nowadays you get titanium also that can be layered, right? So that is a material we used. Again, these are my old cases, but still all of them are doing well. And in spite of the cantilever, you can see on the left side, which I don't give nowadays, but uh, all these things I have been following up for since 10 to 15 years, and I don't see any problem with them, right? Then there is, just like the MLS is, there is a material called Sintron, which is a milled metal. It is provided in a disc form, which is milled first and then sintered into hardened material like this, right? And then composite was layered, ceramic was layered onto it. That's how it looks now. Of course, with Zirconia, this is a case in which the lower ridge was a very poor foundation. If you see, all the upper teeth we preserved, lower we planned all on 5, where since the nerve was placed very much towards the edge coronally, we had to plan 2 angle implants and 3 straight implants in the lower jaw, and upper was also, these are the implant placements, right? Multi units placed. Nowadays we don't use these type of impressions. All we are doing is digital impression. I have a prime scan, which is one of the best scan, which can scan a full arch within seconds, and the accuracy is superior or as good as this type of impressions what we used to take. A Facebook taken, right? The upper prosthesis was delivered, right? These are all zirconia, and lower full contoured zirconia prosthesis was designed and delivered to the patient. If you see, we have kept the multi-unit collars high, and we have given sanitary type of context for self-cleansing. She is my neighbor, so absolutely no complaints. Giving prosthesis to your neighbor is very risky, but she doesn't come with any complaints to me, thank God. And that's how she had come to me and we delivered. Another case, this patient comes to me from Lucknow, close to Lucknow, and he had severe periodontitis. 2013, when my lab was absolutely new. I had recently purchased an Amangirbach, one of my first full mouth cases in my lab where I had done. A scan was taken, most of the teeth were badly shaking. So we placed implants. I placed 3 additional implants for temporization for overdenture. Luckily, even those implants osseointegrated eventually. They were given only for temporary overdenture purpose. That time we never used to immediately load a lot. Nowadays, all the cases we do is immediate loading, but this we used to wait. So for temporaries, we used to add some more implants for temporization. But these temporary implants also integrated, which proves that immediate loading should be done, and huge, of course, with different materials, and you should change the materials later. Again, as I told you, my first temporaries are always PMMA to check how the bite looks, how he smiles, everything, how is the bite, occlusion, everything is changed on there. Then a zirconia framework was made, which was later layered with ceramics, right? Pink ceramic and white ceramic. And this is what we achieved eventually over a period of 6 months. Another full mouth zirconia case, everything planned on exocad, delivered in the patient's mouth, right? So zirconia is my material of choice for full mouth cases nowadays. Gone are the days when we used to feel that 3 unit or more than 3 unit zirconias are going to fracture. If you plan the connectors properly, if your lab is good, if you understand the design of the materials, you can, and if you understand the sintering time of different materials, which very few labs do understand. The newer sintering material machines should, every material has got a different sintering time. Unfortunately, we don't have time today to discuss all these things, but of course, when that's why I keep on insisting to join such forums like what we are having in November. So you will get to know a lot of about these materials, products, and all those things. Another material that nowadays I don't use, since I use a lot of zirconia itself, but titanium framework with full contour zirconia. When the vertical height between the two ridges is too much, then we make a framework of zirconia. These are the implants placed. Again, a 2012 case. A PMMA trial first made for the framework, because the titanium, when milled, it is very expensive material. One arch itself costed me that time. That time I didn't have a lab. One arch nearly costed me 1,10,000 only for the lab bill, right? So all these things we had to do a lot of checks before shifting to the final materials. That's the zirconia crowns BIS trial, and then composite was layered on the titanium, and a final prosthesis was done. Of course, this material is bio. All these materials are excellent. The problem with these materials is the weight, the affordability, and physiology. That's why the newer materials are coming like peak Bio-HPP, which I'll discuss now. So this case, a poor periodontitis case, was made in PEEK with composite layering. You can see a PEEK framework. This case was done with Aslam Inamdar, a prominent aesthetic dentist. Right? You can see how the PEEK has been designed, PEEK framework, and this is her final prosthesis. Right? So I like these material. Number one, for the lightweight. I use these materials more in those cases where I have done a lot of grafting and I don't want a lot of pressure to go to my implants so that the implants will fail immediately. So there are specific indications for this, because these materials are biophysiological, though the affordability is not that great. The only disadvantage of these materials is they are slightly porous, and they can attract plaque. So if they come with high maintenance, you have to remove them and keep on polishing them every 6 months or a year. Then after started using this PEEK, then the materials like Bio-HPP came into the market, which is slightly harder than PEEK. At the same time, it was more polishable than PEEK. So this lady, in which 2 times the implants had failed, and then the number of implants reduced. So we shifted her to this material, and since then she is very happy, and she never came back with a implant that came out from her mouth. So this is Bio-HPP. Composite was layered in her mouth, and that was her final smile that we get. So composites can give excellent aesthetics. We all know about that. And when layered on these materials, even if it fractures, you can repair it in the mouth. Since it is a composite, you can bond any composite to it. Only disadvantage is the roughness on the Bio-HPP material. That's why most of this material should be covered with composites, right? Another case, very poor foundation. This was a condition. My first case with PEEK, that was a wax up trial. Whenever I do a wax up trial, I give a pink and white combination to the patient to see how it is going to look in the patient's mouth. And then a framework plan, composite layered, and this is what we could give. In this patient, I must have grafted bone in each and every part of his jaw. So all the implants are in grafted bone, and they are not there in the natural bone. So I wanted something which was more elastic, so I decided to give PEEK with composite layer. Now the composite layering part also, I don't want any errors into it. And now since digitalization is changing the world, now you can mill the composites on a Bio-HPP product. I'll show you a case that is, this is how we plan. The crowns are made, temporary superimposed on every tooth, right? Then every tooth is very well planned. A framework made, right? First a framework, and you can see on the right side there is a framework which is a Bio-HPP, and down it's a HIPC, that is a composite milled composite material, which is going to be bonded on the Bio-HPP framework. Right? These are the steps which we use. These are the materials that I like to use for bonding composites along with Bio-HPP. You can see. Then these are the staining materials for all the Bio-HPP products. After milling, then for better aesthetics, slight level of layering we do on this HIPC crowns, right? Again, it is digitalized. We made a stent. We make a stent for it for adding colors to it, and that's the final processes that we have. So this is a Bio-HPP framework on composite on Bio-HPP framework and HIPC, that is composite crowns on it. So to conclude, implant prosthetic materials are evolving. Understanding of the materials is much better today than what it was long back. You need more data on newer materials like PEEK, Bio-HPP, and of course, evidence-based science is the key. This is my favorite sentence. This is the only reason that keeps me driving in dentistry is the technology, and the ultimate promise of technology is to make us master of a world that we command by the push of a button. Thank you. Again, I insist all of you to please register for this conclave, as I promise you that the best of the teachers are coming from the world who are doing digital dentistry and implant dentistry are coming, and even the media partners are really putting a lot of efforts to get the maximum from this conference. Right? Please register for this conference. Thank you. I'll hand over to Rajeev. Rajeev?
Thank you, Vipin. That was a fantastic lecture, very, very insightful. And
Thank you.
as I can see, you can minimize your presentation if you want.
Okay. Okay.
Okay. So that was very insightful. You covered a lot of topics, and most importantly, you told your story. You explained how your journey started from the analog times to the digital dentistry times, and how your materials also changed, and how they are constantly evolving. I really wonder how you are able to, keep up your pace with the constantly evolving materials. How quickly you decide to incorporate newer materials, and how expensive it is. That is my question, and I am seeing a lot of questions on the same lines.
I am still on a loaned flat, but my house is still on, but I have got all the instruments and materials available.
Sir, Mumbai property rates are like that only.
Okay, now you have been in digital dentistry and lab for more than 10 years. So when was the first time you started realizing that digital materials are different, and the way they are adapting to the newer workflows, and how it is making a difference?
See, one of the
How many
reasons
years ago was that?
I told you that one of the reason I started entering digital dentistry is, see, I started my career as a periodontist and an implantologist. I used to do a lot of implants. I used to go to nearly 105 clinics in Mumbai and around for my implant and perio. Then I realized that with there was only one CBCT center in Mumbai that time. I'm talking about 2008-9, and most of my patients used to refuse to go to Bandra just for a scan. And I realized that somebody has to do something, so I decided to buy a CBCT machine. People called me crazy that I'm talking about 2010. People called me crazy that he's buying a CBCT machine, but I bought a CBCT machine. And then I started realizing when I was reading this CBCT machine, there is so much information, digital information available, which we miss normally when we are doing. That is the first thing that changed me or shifted me towards the technologies or digital technologies that are available. And of course, with implant industry, I started attending a lot of conferences all over the world, like we are doing it in Pune. And I realized that so many things are not available to us, and somebody has to start something. So, of course, we had very good labs. I used to give a lot of my work to Danish, but Danish used to take hours to days to deliver because he was overloaded. So I decided, since my patients who are coming from abroad, I didn't have time. So I bought my machine, milling machine. First milling, that is 2014. That was an Aman Girbach machine. And suddenly I started realizing there is so many things that can be incorporated in your practice. Unfortunately, because of lack of availability, it is not there. And it was never planned that I will be doing so many things. It was a part of a journey which made me do these things, just so that I can deliver better things which are available all over the world to my patients. Of course, there people charge much differently than what we charge in India. Because I remember one of the conferences in China, all my co-speakers were charging almost $3,000 for implants, and I was ashamed to say that I am not even charging $500 to implants, right? But of course, the materials nowadays, things are available. Patients are getting conscious. I think we should know what these are, and then place them in front of our patients what they need, and let them make the choice.
Right.
So these
Anand,
are.
any question from your side?
I don't see any questions coming in, sir.
Okay, I'll just take from the live audience. How to bond zirconia to tooth structure?
Zirconia is just, most of the people that what we are using nowadays is that zirconia we can lute it with GIC. If you want to bond or you want to use resin based cement, then you can just ask your lab to sandblast the inner structure of the inner structure of the zirconia, that is the crown part of the zirconia, impression part of the zirconia, and bond it just like Emax if you want. Like you can use uh, bonded resins, or even glass iron or cement can be, you can use it for luting purpose.
Okay. Next question. Is printer accuracy necessary despite having a gold standard intraoral scanner?
This is really a very good question. And since everybody has started buying scanners left, right, and center, we are getting a lot of data. Uh, if the printer, it is just like you are using an alginate, you are using the best of rubber-based material, and you are pouring it in plaster. You are getting me. You are getting the best
Yes.
of and places. So if whatever accuracy the rubber-based material is giving you, the plaster is going to just overrule it. Similarly, if you don't have good printers or the good printing materials, not only the printers, the printing materials which are giving, your accuracy is going to get hampered. I'm sure about it.
Like a great painting or great artwork in a very, very average looking frame.
Absolutely right. Absolutely.
Okay, okay. And I think that's all because it's a very new topic and we have covered almost everything. There is nothing left
I know
to be
it
discussed.
is very difficult to ask questions on materials because
There, it was a great, what you can say, afterthought by which I invited Anand here because he is an endodontist and he has written a lot on biomaterials as well. I thought he will ask a lot of questions. And I think Vipin has done a brilliant job. He has covered everything. And what we'll do is, like after every episode of ICPA clinical series, we send 5 point, a 5 point summary of the lecture, 5 take-home points. We will do that tomorrow, and we'll send people to watch the recorded session with the link. We'll be sending it so people can rewatch and internalize a lot of complex concepts that you have described in this session. I think there is one new question. Which scanner do you recommend?
uh, very, see, I cannot be biased to any scanner or anything. All the scanners are good. What, but which I use Prime Scan. I had a Chinese made scan also with me, but definitely there is a huge difference between a Dentsply Prime Scan and the local Chinese scanners that are available, especially when it comes to the depth or anything. But if you go to the internet, you can see that scanners like Prime Scan, Medit 700, i700, then one scanner from Carestream is very good. Then um iTero scanners are good. These are recommended companies which are very well studied. See, rest of the scanners have come to the world without any studies. They've just put some cameras into it and there. So if you want a good depth, good color, you should always buy a reliable company scanner. It is a one-time investment. You can't keep on buying scanners. So if you're pouring some lakh of rupees on a scanner, might as well put more and buy the more reliable or more studied scanners.
Great.
Three Shapes is another good scanner.
Okay. Do most of the labs do this Bio-HPP in and HIPC processes now? Any lab brands you would recommend?
See, we do it in our lab, that is Synergy Dental Lab, that is for sure. I am doing it since almost now 5-6 years. I am using Bio-HPP and HIPC. I don't know much about other labs, that you'll have to inquire to your labs only, because since I don't have any access to other labs. But of course, we do it. If you want, you can send it to our lab, or you can check with your labs around and find out. But they are definitely very good materials. You can try on your implantations. Yeah.
So for more information, they can contact Synergy Dental Lab Mumbai. That is Dr. Vipin Mahurkar's lab. Okay. And approximate cost.
Approximate cost of HIPC means it will be around 3,500 to 4,000 per unit, somewhere around per unit.
Okay. Per unit.
Slightly higher than Zirconia, that we good quality Zirconia that we are using.
Okay. Okay. Now, before we wind up, my question to you is, if somebody plans to follow your footsteps and wants to enter digital dentistry, and simultaneously he plans to start his own lab as well, what will be your advice to them? How slowly they should take it and how step by step they should go?
See, starting a lab is itself is a big investment, and it is an
Yes.
ongoing investment. It is, if you think about it financially, you should be very financially sound. And the most difficult part of running a lab is the HR part of it, is having good people working with you, right? You have to develop those people. So you should start with a single unit. I feel this, nowadays you get good cheap printers. Start with printing machines, buy exocad, start with all these softwares first, and then slowly start shifting towards milling machines, MLS machines, all these machines that are available in the world.
Okay.
Um, if you have a big heart, then to take all the stress, then start a lab. Otherwise, it is a difficult process. I can say. Okay, Exocad certification program.
Yeah. Do you recommend this
I,
Exocad certificate program that you are
I,
having in?
I absolutely recommend this program, because in future you will have to plan your own crowns, you will have to design your own crowns and mill your own crowns. That is the next generation of these MNCs are going to sell these products to you. You should be well trained, to. And Exocad is one of the best software and easy software to learn. So please, I would ask everybody to join this program. I think there are limited seats for this. I think we are taking only 20 to 25 people, because the availability of that hall is not more than 25 for the pre-conference. That is the Exocad program. So if you want to register, register fast for this. Before that,
When is
they will have to register to the ISDD program.
yeah. When is the early bird ending? August tomorrow, 31st August.
I think so. Yes, 31st. Yes, yes. Tomorrow it is ending.
Okay. So if you want to
So get
register, you can
if
look
you
at
want
this.
to. Yeah. Please, this side. Yeah, get it registered as early as possible. Today
Okay.
only.
Yeah. Tomorrow is the last day, I guess.
Yeah.
Fine. So I'll just see if there is any other question. Okay. A lot of compliments coming in. Thank you, Vipin. Thank you for taking out your precious time. You are doing a lot of things. Your hands are full, but you agreed for this episode and you gave a brilliant session for all of us and for all the people who missed it live but and are going to watch it again through the recorded session on YouTube later. And I also thank ISDD, Indian Society of Digital Dentistry, for coming up with this series. We are finishing 3 episodes, and soon they'll be announcing their 4th episode. I also thank Dr. Anand Mohta and Dr. Abhishek, the founder and co-founders of World Dental Association, for powering this entire educational series. And thank you everybody for joining in. And wait for our next announcement. We'll be announcing the episode number 4 very soon. Thank you and good night.
Thank you. Rajeev. Thank you. Thank you. I hope we have made
Good night.
justice to everybody. Yeah. Everybody's tenure. Bye.